Welcome to our channel Medicine A to Z. Today, we are going to discuss about COPD in terms of pathophysiology, classification, and updated GOLD guidelines. GOLD definition of COPD. COPD is a heterogeneous lung condition characterized by chronic respiratory symptoms due to abnormalities of the airway and/or alveoli that cause persistent, often progressive airflow obstruction. GOLD, the Global Initiative for Chronic Obstructive Lung Disease, a project initiated by the National Heart, Lung, and Blood Institute and the World Health Organization. Chronic obstructive pulmonary disease, or COPD, is influenced by a variety of factors. Let's explore the key risk factors associated with the development of COPD. Smoking. Smoking is the leading cause of COPD. The harmful chemicals in tobacco, smoke damage the airways, leading to inflammation and obstruction. Occupational exposure. Prolonged exposure to occupational hazards significantly contributes to COPD risk. Dust, chemicals, and fumes in certain workplaces can damage the lungs over time. Indoor air pollution. Biomass fuels, such as wood and crop residues, contribute to indoor air pollution. Poorly ventilated cooking areas expose individuals to harmful pollutants, increasing the risk of COPD. Genetic factors. Genetic predisposition plays a role in COPD development. Alpha-1 antitrypsin deficiency, a hereditary condition, increases susceptibility to COPD. Age. Aging is a natural risk factor for COPD. The majority of individuals diagnosed with COPD are over the age of 40. Respiratory infections. Recurrent respiratory infections, especially during childhood, may elevate the risk of developing COPD later in life. Early life respiratory issues can contribute to long-term lung damage. Airway hyperresponsiveness. Some individuals may have heightened sensitivity in their airways. This heightened responsiveness makes them more susceptible to inflammation and obstruction, ultimately increasing the risk of COPD. History of tuberculosis, TB. A history of tuberculosis, TB, can contribute to lung damage. This damage, over time, elevates the risk of developing COPD. Poor socioeconomic status, limited access to healthcare, poor nutrition, and exposure to environmental pollutants due to lower socioeconomic status contribute to the risk of COPD. Addressing socioeconomic factors is crucial in managing and preventing COPD. Gender. Historically, COPD has been more prevalent among men. However, as smoking patterns change, COPD rates in women are on the rise, emphasizing the need for awareness and intervention among all genders. Childhood respiratory issues. Children with frequent respiratory infections or asthma may face an increased risk of developing COPD later in life. Early identification and management of childhood respiratory issues are vital in preventing long-term lung complications. Chronic obstructive pulmonary disease, or COPD, is a complex respiratory condition with distinct variants. Let's explore the two main types of COPD patients. Chronic bronchitis. Chronic bronchitis is one variant of COPD. It is characterized by a persistent and productive cough, lasting at least 3 months each year for 2 consecutive years. The chronic inflammation of the bronchial tubes leads to increased mucus production, contributing to airway obstruction. Emphysema. The second variant is emphysema. Emphysema is defined by the permanent dilatation of pulmonary air spaces distal to the terminal bronchioles. In emphysema, the walls of the alveoli are damaged, leading to reduced elasticity and impaired gas exchange. Chronic bronchitis is characterized by persistent inflammation of the bronchial tubes, leading to a cascade of changes in the respiratory system. The irritants cause an excessive production of mucus in the bronchioles. The ongoing irritation results in hypertrophy and hyperplasia of mucus glands within the bronchial walls. This overactivity contributes to an overproduction of mucus, a key hallmark of chronic bronchitis. With prolonged exposure to irritants, the delicate cilia lining the bronchial walls can be damaged. The cilia, responsible for moving mucus out of the airways, become shortened and lose their effectiveness. The cumulative effect of excessive mucus and compromised cilia leads to narrowing and obstruction of the airways. This narrowing results in increased resistance to airflow and difficulty in breathing. Air trapping. Let's explore the intricate pathophysiology of emphysema, a variant of chronic obstructive pulmonary disease, COPD. Emphysema involves the gradual breakdown of lung tissue, impacting respiratory function. Emphysema begins with exposure to irritants, commonly from cigarette smoke or occupational pollutants. These irritants activate alveolar macrophages, the immune cells within the alveoli. Activated alveolar macrophages work to engulf and remove irritant particles through a process known as phagocytosis. As a response to the irritants, activated macrophages release signaling molecules called cytokines. Cytokines play a crucial role in the immune response and inflammation. Cytokines attract neutrophils, another type of immune cell, to the site of irritation. Neutrophils release enzymes, including elastase, to neutralize the irritants. Elastase destroys elastic fibers of alveoli. The destruction of elastic fibers reduces the lung's ability to recoil during exhalation. This loss of recoil leads to air trapping, where the alveoli remain expanded, making it difficult for the lungs to effectively expel air. Both chronic bronchitis and emphysema, as discussed earlier, involve air trapping in the lungs. This persistent air trapping sets the stage for complications, including pulmonary hypertension. In chronic bronchitis, the airways are obstructed, impacting both the entry and expulsion of air. Even in early stages, hypoxia and hypercapnia are present due to compromised gas exchange. In emphysema, hypoxia typically occurs at later stages as a consequence of reduced lung elasticity. The breakdown of elastic fibers leads to inefficient gas exchange, causing hypoxia. Hypoxia triggers vasoconstriction in the pulmonary arteries, increasing resistance to blood flow in the lungs. This pulmonary vasoconstriction is a key driver of pulmonary hypertension. Pulmonary hypertension, the increased pressure in the pulmonary arteries, results from the elevated resistance. The heart has to work harder to pump blood through the narrowed vessels. The increased workload on the right side of the heart causes hypertrophy of the right ventricle. Over time, right ventricular hypertrophy can progress to right ventricular failure. Let's examine the distinctions between chronic bronchitis and emphysema, two variants of chronic obstructive pulmonary disease, COPD. Each presents with unique features, leading to differences in patient characteristics. Chronic bronchitis is primarily characterized by excessive production of mucus in the bronchioles. Emphysema, on the other hand, is characterized by the destruction of alveoli, the small air sacs in the lungs. Chronic bronchitis patients tend to experience hypoxia in early stages due to compromised gas exchange. In emphysema, hypoxia typically develops at later stages as a result of reduced lung elasticity. Cor pulmonale, or right heart failure secondary to lung disease, is more common in chronic bronchitis due to early hypoxia. In emphysema, cor pulmonale is less prominent, given the later onset of hypoxia. Patient nicknames. Chronic bronchitis patients are often referred to as blue bloaters due to cyanosis and possible obesity. Emphysema patients are known as pink puffers, reflecting their characteristic pursed lip breathing and often thin or cachectic appearance. Lung appearance in radiography. Chronic bronchitis may present with a normal-sized lung or exhibit a dirty lung appearance on radiography. Emphysema is characterized by hyperinflated lung fields, potentially with bully raunchy or coarse rattling sounds, are common in chronic bronchitis. Raunchy are less common in emphysema. Cough is an early sign in chronic bronchitis, often preceding dyspnea. In emphysema, cough is less common and may occur after the onset of dyspnea. Diagnosis of COPD. The key parameter in diagnosing COPD is the FEV1 to FVC ratio, and the response to bronchodilators provides additional insights. The cornerstone of COPD diagnosis lies in the pulmonary function test result, specifically the FEV1 to FVC ratio. A ratio below 70% indicates airflow limitation, a characteristic feature of COPD. To further solidify the diagnosis, a bronchodilator, typically a short-acting beta agonist, is administered via nebulization. If there is no significant improvement in the FEV1 to FVC ratio after bronchodilation, it reinforces the diagnosis of COPD. Normal spirometry excludes COPD. DLCO measurement provides additional information in distinguishing between the two main COPD variants, chronic bronchitis and emphysema. DLCO in chronic bronchitis. In chronic bronchitis, DLCO is often normal since the alveoli, responsible for gas exchange, remain intact. In emphysema, DLCO is reduced due to the destruction of alveoli, compromising the lung's ability to transfer gases effectively. Supportive investigations. Arterial blood gas analysis, or ABG, is recommended when oxygen saturation levels dip below 92% or when there are signs of altered mental status. Chest X-rays are valuable for detecting specific changes in lung structure. If we observe hyperinflated lung fields or a barrel chest on the X-ray, it provides valuable insight into the extent of lung damage and helps guide treatment decisions. CT scans of the chest. These are particularly useful for identifying structural abnormalities like bully and air trapping. The alpha-1 antitrypsin test is recommended for all COPD patients. Lastly, a complete blood count can reveal important information about the patient's health status. In COPD, an increased hematocrit level may indicate chronic hypoxemia and the body's compensatory response to low oxygen levels. Clinical indicators to considering the diagnosis of COPD. First on the list is dyspnea, a progressive or persistent shortness of breath that worsens with exertion. Next, we have recurrent wheezing, a sound that can't be ignored. Chronic cough takes center stage next, may be intermittent and may be productive. Another indicator to consider is the recurrence of respiratory tract infections. Lastly, consider history of risk factors, especially tobacco use. Staging of COPD. GOLD Class 1. In this stage, individuals experience mild symptoms, and their FEV1 is more than 80% of the predicted value. Moving on to GOLD Class 2. At this stage, symptoms become a bit more noticeable, falling under the category of moderate. FEV1 now ranges between 50 to 80% of the predicted value. Now, let's talk about GOLD Class 3. Symptoms take a more severe turn here. It's like a storm brewing in your lungs. FEV1 drops between 30 to 50% of the predicted value. Finally, we have GOLD Class 4, the most severe stage. At this point, symptoms are very intense, and FEV1 is less than 30% of the predicted value. Symptom assessment in COPD. Healthcare providers use two powerful tools for assessment: the Modified Medical Research Council, MRC, dyspnea scale, and the COPD assessment test, CAT. The MRC scale focuses on one vital aspect: breathlessness. Patients rate their breathlessness on a scale from 0 to 4, providing valuable insight into the impact on daily activities. But COPD is more than just breathlessness. That's where the CAT questionnaire comes in. The CAT questionnaire delves deeper, exploring 8 key areas: cough, phlegm, chest tightness, breathlessness, activity limitations, confidence in leaving home, sleep quality, and energy levels. Patients rate each area on a scale from 0 to 5, painting a comprehensive picture of their COPD symptoms and their overall impact on life. By combining these tools, past exacerbations with healthcare providers can tailor treatment plans. CAT assessment of COPD. It is easy to administer. It has been validated through clinical trials. It provides scores ranging from 1 to 5 for each category across 5 different topics. A score of more than 15 indicates a higher likelihood of COPD exacerbation. GOLD ABE assessment tool. Management options are not solely dependent on the stage of COPD. Rather, they are determined by the presence of treatable traits. These treatable traits are influenced by both symptom burden and the risk of exacerbations. In the newer GOLD ABE assessment, 3 treatable traits are identified by incorporating characteristics from the previously categorized C and D traits. Treatment goals. When it comes to managing COPD, the treatment goals are clear and focused on improving quality of life. 2 primary objectives guide the path to better health. Firstly, reducing the burden of symptoms is paramount. Every breath should be easier, every day less burdened by coughing, wheezing, and breathlessness. Secondly, minimizing the risk of exacerbations is crucial. By keeping flare-ups at bay, we aim to maintain stability and prevent setbacks in your journey towards better respiratory health. Management of COPD. Managing COPD effectively requires a personalized approach tailored to individual needs. For those in Group A, a single bronchodilator therapy is typically recommended, either a LAMA or a LABA, to help ease breathing and improve lung function. In Group B, dual bronchodilator therapy is the way forward. Combining a LABA with a LAMA can provide enhanced relief from symptoms and better control over your COPD. Moving on to Group E, where things may get a bit more nuanced. Here, the recommendation is LABA plus LAMA with ICS, but only if your eosinophil count is elevated, exceeding 300. This combination can be particularly effective in managing inflammation and reducing exacerbation risk. Remember, this initial therapy approach sets the stage, but adjustments can be made based on your response during follow-up. If you're not seeing the desired improvement, we have options to escalate the therapy. Stay updated with the latest in medicine. Subscribe to our channel for comprehensive videos covering the latest updates in the field.